So welcome to part 4 of our series on inpatient hyperglycemia from crisis to control. In this segment, we'll focus on insulin therapy in critically ill patients where hyperglycemia can destabilize outcomes if not managed precisely. Now, IV insulin, guided by validated protocols and sensitivity-based algorithm, offers safe, responsive control tailored to each patient's condition. So let's explore how these transform high-risk glucose patterns into a manageable part of critical care. Now, I would like to start with this important data adapted from the pivotal study by Jeffrey Kinsley, published in Mayo Clinic 2003, examining the link between hyperglycemia and hospital mortality in a diverse ICU population. This research was among the first to demonstrate that stress-induced hyperglycemia in critically ill patients is far from harmless. It emphasized that proactive glucose control, even in those without diabetes, can significantly reduce mortality. The data revealed a clear graded relationship. As mean blood glucose level rise, so does the risk of death. Mortality begins to increase once glucose exceeds 110 milligrams per deciliter and escalates sharply beyond 180 milligrams per deciliter regardless of diabetes status. This trend underscored that elevated glucose in the ICU setting isn't merely a reflection of illness severity. It is a driver of poor outcome. The core message is that hyperglycemia in critical illness demand attention. Tight but safe glycemic control, avoiding both extremes, may be life-saving. Now, elevated blood glucose upon ICU admission was found to be an independent predictor of increased hospital mortality, even among patients without known diabetes, here represented as a new hyperglycemia, likely reflecting stress-induced hyperglycemia. Instead of being a mere byproduct of critical illness, this hyperglycemia actively worsen outcomes. So, early detection and timely intervention can significantly improve survival. Now, mechanistically, severe illness activates a surge of stress hormone such as cortisol and epinephrine, which reduce glucose uptake in skeletal muscles. These hormones also enhance lipolysis, leading to insulin resistance in both muscles and liver tissues. This cascade results in elevated blood glucose level, a condition referred to as stress hyperglycemia. Now, stress hyperglycemia triggers a critical illness, not only reflects metabolic disruption, it actively worsens the disease process. Beyond impaired glucose handling, it contributes to the cascade of complications, including hemodynamic instability, electrolytes imbalances, oxidative stress, and cardiac injury. It also promotes hypercoagulability, immune dysfunction, delayed wound healing, heightened inflammation, and impaired endothelial function, amplifying the severity of critical illness. Now, inpatient hyperglycemia management varies based on the clinical severity and care setting. For non-ICU patients, the standard approach is a basal bolus insulin regimen which covers both scheduled and correctional doses that we already detailed in part 3 of this series. In contrast, critically ill patient in ICU setting requires a more intensive strategy due to metabolic instability previously discussed. This often involved intravenous insulin infusion. So there are two main IV insulin protocols. The variable rate IV insulin infusion, abbreviated here by VRIII or triple I, used for ICU patients with stress hyperglycemia. The other one is the fixed-rate IV insulin infusion, or abbreviated here as FRIV, reserved for hyperglycemic emergency like diabetic ketoacidosis and hyperosmolar hyperglycemic state, or HSS. In this part 4 episode, we'll focus on the variable rate regimen. The fixed rate protocol will be covered in the next installment. Now, IV insulin in critical care. Why and when do we use it? In critically ill patient, IV insulin offers rapid, precise glucose control with reliable absorption, even in poor perfusion state like hypotension. Its safer titration helps reduce hypoglycemia risk and improve outcomes in stress hyperglycemia. It is essential, therefore, in unstable scenarios like sepsis, shock, post-op ICU care, DKA, HHS, multi-organ failure, or even patient-required vasopressors or mechanical ventilation. In this setting, IV insulin is the fastest, safest, and most effective options. Again, the condition that warrants IV insulin infusion in table form, IV insulin is preferred in critically ill patient because it offers fast, precise glucose control and reliable absorption even when perfusion is poor. It is therefore essential in conditions like sepsis, post-op ICU care, ACS, multi-organ failure, and when patients are sedated, ventilated, or on vasopressors. In emergencies, hyperglycemic emergency like DKA and HHS, a fixed-rate protocol is used instead. Now, using a standardized insulin infusion protocol in the ICU helps ensure consistent evidence-based care. It reduces blood glucose variability, improves safety, and leads to a better clinical outcome. While protocols may vary across institutions, it should be validated and adapted to meet the specific needs of the ICU patient population. So an ideal IV insulin protocol should be simple to order, easy for nurses to implement, and effective at safely reaching glucose targets. It must include clear algorithms for adjusting infusion rates, minimizing hypoglycemic risk, and support nutrition and electrolytes, all while maintaining blood glucose within a defined range. One example of variable rate IV insulin infusion protocol is the Texas IV insulin infusion protocol, which is validated, nurse-driven approach designed for critically ill or fasting patient whose blood glucose exceeds the target range. It begins with a standardized insulin concentration, typically 1 unit per ml to regular insulin in a normal saline, and adjusts infusion rate based on hourly glucose measurement. It has a built-in algorithm, a guide safe titration while minimizing hypoglycemia. The protocol offers 4 tailored pathways: standard, sensitive, resistant, and very resistant, based on the patient's insulin sensitivity and clinical condition, ensuring responsive and effective glucose control in ICU setting. So in summary, IV insulin transforms inpatient hyperglycemia from unpredictable to controllable, especially in ICU settings. Validated infusion protocol ensures safe, effective, and tailored glucose control. Hourly titration safely checks and sensitivity-based algorithm guide precision care. Protocols adapt to each patient's clinical context, minimizing risk and improving outcomes. Part 5 will explore the hyperglycemic emergency protocols, the fixed-rate IV insulin infusion that are used for diabetic ketoacidosis, and hyperosmolar syndrome. From stress hyperglycemia to metabolic emergencies, insulin remains a powerful evidence-guided tool. So up next is part 5, hyperglycemic emergency in insulin protocol with the use of fixed rate IV infusion for DKA and HHS. Thank you so much for listening.